Testosterone is an essential hormone also in women, and the most important function most likely is the fact that it's the building block or the precursor to the manufacturing of estradiol in the ovary. This is important in the context where we think about testosterone replacement, because if estrogen is not adequately replaced, all the testosterone we give will just be metabolized in the ovary to estradiol. When we consider replacing testosterone in women, let's just think about the normal effects. So it's clearly associated with mood. It's associated with muscle and bone strength. And specifically in the peri and the postmenopausal area, there are associations with sexual functions such as libido, orgasm, and so on. The route of administration is quite important. So when we reach high levels of testosterone in the liver, one gets a lot of metabolic side effects, and this is the atherogenic or the pro-cardiovascular disease lipid profile or cholesterol profile. We also see that you get a redistribution of fat from the peripheral areas on into the stomach, where it increases insulin resistance. And the reason for this is that testosterone undergoes first pass metabolism in the liver. So the liver, in fact, metabolizes testosterone to a lot of inactive or less active compounds. And therefore, to reach the systemic effect, you inevitably expose the liver to significantly high testosterone levels. And this might happen even before the cosmetic problems that patients would experience. What are these cosmetic abnormalities? Well, mild pattern baldness, hair growth in areas that you don't want, and hair loss in areas that you want it, and things like clitoromegaly and acne. In whom is it absolutely indicated to replace testosterone? These are women that have premature ovarian insufficiency or a very early premature menopause, so that is women younger than the age of 40. In those women, after they have their ovaries removed, there's a drop in testosterone by at least 50%, so it's important to consider replacement in them, and also in women that are younger than 45 when they experience or start to experience the menopause. Most evidence is in the perimenopausal and postmenopausal context, where testosterone is linked to a sexual function mostly, also to a depressed mood. And it's just important that before we replace testosterone, we make absolutely sure that it is the testosterone that's the issue. Because if you test the blood and the testosterone of the women that have these symptoms are high, it's clearly not something that you could address. So either there's something else cooking, or there's an issue at the receptor level where the testosterone might not be able to function. And for that, one cannot, unfortunately, do anything. So testosterone or free androgen index must be less than 1% when we consider, or in the lower quartile of your laboratory reference range, before we consider replacement. If we replace, we try to avoid the oral route and go transdermal. Avoid any depots, because then if it's in and you can't do anything to reverse the effects for a long time. And when we replace, we give at least or most at 10 or 5% of what we would potentially replace men. Important to recheck the free androgen index level at 3 to 6 weeks. And if the free androgen index increases, then you know that the risk of the metabolic and the potential cosmetic side effects is on its way. Probably the most biggest problem from a medical legal perspective is that there's no testosterone product registered in South Africa and in many other countries for the use in women. So by doing testosterone therapy or giving testosterone therapy, and one must consider the risk-benefit ratio, also the medico-legal consequences due to the fact that there are really no registered product for females. Testosterone can be used if it's used well and for the right purpose, and if it's monitored appropriately. So there's clearly a role for testosterone replacement in both pre- and postmenopausal or perimenopausal women, provided that it is well managed.